Hi team, it's Heather. We've put together this tutorial for you on FLOLAN to help increase your comfort and confidence in administration of FLOLAN, the nebulized treatment. The four components are Colin Feeney is going to talk to you about administration of FLOLAN and those considerations. Second part is the policy, and keeping in mind the policy is on Policy Tech. The third is going to be a video on the administration of the nebulized treatment. And keeping in mind that on the video, it has a different product there that attaches the nebulized treatment. So just keep in mind there's a different device that we use. And the last thing will be a post-test. So without further ado, we will get to Colin. But I just want to say in the meantime, thank you for all you do, and thank you for all the hard work you do for our patients. On to Colin.
Hi, so ARDS is a disease characterized by alveolar flooding. And normally speaking, the lungs are an auto-regulatory unit, so that when you perfuse an alveolus, if it's filled with fluid, normally speaking, the pulmonary arteries would clamp down and not perfuse this alveolus, as opposed to a normal alveolus, which would be ordinarily perfused. Because of the inflammation in ARDS, there is cytokine activation, and the pulmonary arteries inappropriately dilate, and so they perfuse alveoli that are filled with fluid. This causes a terrible shunt because this oxygen, this blood coming back from this unventilated alveolus is very low in oxygen, and even though you mix it with oxygenated blood from a good alveolus, you can't get the PO2 up. So this is a huge problem in ARDS. So what can we do about that? And we have a number of treatments, including high PEEP to try to open up alveoli which have collapsed, high flow oxygen, proning, etc. But we also use inhaled FLOLAN, I should say inhaled prostacyclins. These are smooth muscle relaxants which dilate the pulmonary arteries. They also have some anti-inflammatory, antiplatelet activity, but predominantly they are smooth muscle arterial relaxants. When you give them inhaled, they go to the alveoli that are open, and they increase the blood supply to the alveoli that are open. Okay, so this is going to decrease the shunt and help you with oxygenation. There's no data about increasing survival, as is true for many of the modalities we use for ARDS, but they buy you some time while you do lung protective strategies to allow the lung to heal. So prostacyclins, we always talk about FLOLAN because it's easy to pronounce, but there's actually two products which are both prostacyclins, FLOLAN and Velletri. FLOLAN requires a special diluent and it only lasts 8 hours once it's mixed up, whereas Velletri can be mixed in normal saline and lasts 24 hours. It's also cheaper, so this is now our go-to inhaled prostacyclin. And so we would administer that in line with a nebulizer at 50 nanograms per kilogram per minute, and then taper it down once the oxygenation for the patient improved. So this has been used extensively at Highland for many years, and again, it's one of the tools that can help us reduce the FiO2 for these patients and buy time to allow the lung to heal.